On today's Nurses Uncorked, we're going to be diving into the dark side of these long-term care facilities and what really goes on behind the scenes um, with our friend Masshole Maguido, who works in the long-term care field doing wound care. This is an episode that you are not going to want to miss, especially if you are ever in the position of having to place somebody in a long-term care facility. We're going to give you all the tips and tricks of what to look for and dive into what really is going on. I'm Nurse Jessica Seitz.
And I'm Nurse Erica.
And we're Nurses Uncorked,
the podcast that takes nursing facts
with nursing comedy and makes a little cocktail out of it.
Don't forget to hit that subscribe button wherever you listen to podcasts, and please rate, review, and download.
Hello, everybody. Welcome back to another week of Nurses Uncorked. Boy, do we have an episode for you today. Nurse Erica and myself have our dear friend Matthew with us. Woot woot! Welcome back, Matthew.
Hi,
ladies. If you guys don't remember, we've had Matthew on a couple times already. Or you may know Matthew as the Masshole Maguido. Maybe just Matthew, or maybe just Sexy Boston Man. We're not sure what you describe him as, but we do know he's our friend, and he's been on episode 3 where we talked about workplace violence, right, Matthew? Then we had episode 30 where we talked about nurse burnout. So if you recall those episodes, and now he's back again, and he is winning a prize today. Did you know that, Matthew? You win
I didn't
most
know that.
returned guest. Yes.
Yeah.
I don't know what we're giving you, but
what do I get? Well, I got this. I did get this.
Oh,
okay.
He's wearing my shirt, my merch.
I did get this, but I don't know if this counts as a prize because I got it prior. So maybe I need.
And if you don't know what the shirt says, what does it say, Matthew?
Once upon a time, the nurses collectively, I can't read it backwards.
Demanded
change, and they lived happily ever after. The end.
I feel like we're like rubbing nipples on the podcast there. I'm like,
available at the Nurse Erica on Etsy.
Very comfortable.
She can put a link in the description. I'll allow it. I'll allow it.
Dries beautifully. Free shrunk.
Thank you.
Yeah, perfect.
Thank you.
When do I get one? Shoot.
I miss
Where's mine?
girls.
So
it's been crazy lately.
Can we talk about you, Matthew?
Yeah, tell us. Tell us all about him.
Matthew is a ex-porn star. No, I'm just kidding.
I mean, luckily we're all of an era that the internet wasn't available at the phone, so there's not really any evidence of.
Yeah, before in his former life he might have been. No, all kidding aside, Matthew's a registered nurse with an extensive background in psychiatric nursing, and more recently he's added home health care and wound care to his specialties.
That's what we're doing.
He is also a legacy nurse, meaning he comes from a multi-generational nurses that are in his family, which we want to get his mom on one day. We're going to have to do that.
I don't even know what that would look like.
I'd be fun. That's all I know.
What would that look like?
Mama Matthew. This and his outspoken nature gives Matthew a unique perspective and voice. And today, he's here to help us navigate and expose the difficult and often controversial subject of long-term care nursing, and specifically the corruption surrounding it. In a recent episode, Erica and myself mentioned that medication techs were replacing nurses in some areas of long-term care, and people did go a little nuts about it. Erica had a lot of comments, a lot of comments.
There was some nastiness. It was. That hit a nerve. With some people.
They basically were saying that was not true and it was a big lie. So we'll get into that as well today. But we promised that we would get into an episode to discuss all of that in detail. So that's what we're doing today. So today we'll be discussing that and a lot more. So if you have a loved one in an assisted living or in a nursing home, you absolutely need to listen to this episode because we are going to be exposing all the things that they do not want you to know. So you do not want to miss today's episode. We're gonna hit it all.
But
before that,
yes, what do we have? What are we drinking today, Jessica?
We're having alcohol.
Yes,
we need it. Let's bring it on.
Yeah, I've been waiting to get this started. So today we are doing a whiskey sour. This is a new one we've never done before. So this is it's actually
Jessica,
it's a little bit complicating. What?
Jessica,
What?
we did do a whiskey sour before.
We did? Oh, well.
And I dubbed it the Union Buster.
Remember? Oh, well, when I make it right now, I want you to tell me if we made it the same way, because I don't remember at all you making it.
We're going to have to start like a spreadsheet so we can keep track.
Damn. Okay, this is the Jessica whiskey sour, okay?
All right, let's do it.
So let's do it. So you're going to take, I already put a little bit of the ingredients in here for time's sake. You're going to take about a tablespoon of freshly squeezed lime juice, which I actually did that.
We love lime.
Yeah. You're going to take a tablespoon of a simple syrup of any type. I just got one from the liquor store. I don't know. Was it one of the cheaper ones? Then you are going to take several splashes of aromatic bitters. I think mine's more complicated than yours, Erica.
I think so.
Yeah. You probably had a pre-mixed one or something. Erica's
no, but I remember I used maple syrup for the simple syrup.
Then my husband's making me open this. What?
Did she just say she used maple syrup as her
simple? I did, if I remember correctly.
Or are you eating it with pancakes?
I swear the recipe said you could do that. I swear.
Well, I did read you could use honey, so I believe that.
See?
You probably could.
Yeah.
So my husband asked me to open this on camera because supposedly this is a very expensive bottle of whatever whiskey, Kentucky straight bourbon whiskey. And it's got this is like a melted wax candle top, which is kind of cool. So I told him that I would, and watch it. Probably won't open properly, but I'm gonna give it a whirl.
Last time you tried to open something, you almost took an eye out with the cork.
Oh no, it opened okay.
You're gonna take your eye out.
1.5 ounces of whiskey. God, I can't wait for this.
That sound. It was a sound for me. It's a sound for me.
You're gonna pour it in. I have my Nurses Uncorked shaker. Yep. Nice. Adding all of these other good ingredients here.
I don't have one of those.
Oh,
we will send you one.
So funny.
That's going to be your prize for being
there we go.
Yes.
Oh yeah. Mm-hmm.
That's for people that. What is it called? ASMR? I don't know.
ASMR.
Okay. And then you're going to garnish it with a little lime. And
let's see it.
There's Jessica's whiskey sour. So cheers, everybody.
Nice.
Salud.
Cheers.
I have my cocktail in my Halloween cup, even though this will probably be post-Halloween.
Beautiful.
That is good. I'm already feeling warm. I already feel it going down.
We need it because this is a heavy topic that we're getting into today.
It's a topic that I think most people know about or have heard about because, there's been so many news stories that have covered things. You've heard tragedy stories, you've heard horror stories. But for some reason, never gets the attention it deserves or needs.
Yeah, well, I think it gets covered up, and we'll talk about that too.
We will. So let's do it.
Let's get into it. Let's talk about staffing requirements in ALF, assisted living facilities, or memory care, memory support. It's called different things in different areas.
So
as far as like contact hours, nurses required, different types of facility licensure requirements, that good stuff.
So I'll start with this. Just we'll do it this way because I can already hear the comments in my head. So when you had posted that video, people saying that this type of stuff wasn't happening, right? I think what needs to be kind of driven home is every state is different. Okay.
Yes.
And so just because, I'm from Massachusetts, I now live in Florida. Jessica's in Florida. You're in Vegas. You know what I mean? So just because it doesn't happen in your state does not mean it's not happening in one of ours or someone else's state.
Or in your facility. It can happen in the facility down the street and you not be aware of it.
Exactly. So I'm glad you mentioned that. So unfortunately, and I will be the first one to admit, even having previously, worked in this setting, a time ago, and now as a wound care nurse, I go into this type of setting, not employed there, but I go in there weekly. As you know, I talk to you, and I'm telling you I'm going in and what I'm seeing. Each facility and the regulations are very confusing. they're allowed to somewhat form their own policies. They have to follow, of course, the blanket state reg, but they're allowed to form their own individual policies. So, like you said, just because it's not happening at, assisted living 1 doesn't mean it's not happening at assisted living 2. And that does not mean that just because assisted living 1 and 2 in Florida are doing it, that necessarily Texas is doing it. So I think that's in the comments when I was looking at the video. From what I was seeing, my understanding was people were saying, oh, that's not true. It might not be true in your state or in your facility, but it is true. And I'm here to tell you it is true because, I mean, if there's one thing I'm not, is a liar. And I see it every day. Erica knows I see it every day. I call them when I see these things. So it is happening. I can only speak for myself and for what I see in the state that I'm in. But in videos that I've posted as of late, there's girls from Tennessee, North Carolina, Connecticut, New York, all saying, where I work, it's happening. Where I work, it's happening. But in that same respect, there'll be a girl from New York who'll say, oh, but not in my facility.
It doesn't happen here.
Yeah, that's great that it's not, but it does happen a lot.
Of course it does. And so I think we should preface with, let's start with, just because you're not aware of it or it's not happening where you work or live, we're not going to blanket statement it's not happening at all, because it is happening. So
and there's different levels of care, and so just because it doesn't happen in skilled nursing in one place does not mean that it doesn't happen in skilled nursing in another place. There's different levels, right? There's ALF, there's all these different levels. So you guys have to really get past that mindset and realize that corruption is real. And while what we're going to talk about today is alleged, it's happening. And just because you don't see it doesn't mean it's not happening.
To that point, when you said skilled nursing facilities, I also saw that in the comments as well. One thing we can clear up now is a lot of people are saying, no, that's not true because of Medicare and regulations. That part's correct. SNF, skilled nursing facility, this will go to the first part of your question, they do receive Medicare monies. So ratios do apply in that setting. In assisted living, in memory support, it's not the same. So you asked about licensure. So the license, there's different versions of the license. There's the standard licensure, which they offer, minimal medical services. Then there's the LNS, the limited nursing services. Again, this is Florida, where that they will offer they'll pass medications, or maybe if there's a skin tear, maybe possibly that's even pushing it, can put a dressing on, maybe vital signs, things of that nature. Then there's the ECC, which is the extended congregate care, and that's what I was familiar with when I started. Extended congregate care is you will have patients with sleep apnea. You can treat them; they can have their treatments. You'll have ostomies. You will be doing the wound care. Home health won't necessarily be coming in. The only providers that were really coming into that facility at that time, if I remember, and again, this is pre-COVID, and I'll expand on that, was hospice for CC, crisis care, and crisis care, and patients that were just receiving hospice treatment. So something that you'd be more familiar with. You know what I mean? But home health, I don't really recall home health coming into that particular location, but they didn't need to because of the extended congregate care license. Now, that being said, in those facilities, you would see nursing because of the services that have to be provided. That does not mean nursing is in the building 24 hours a day. That just mean not mean nursing is in the building Monday through Friday, Saturday, Sunday. It varies. So the regs are different, like I said, every state, every place, but for like a memory support, you'll probably have a nurse. Some facilities I know have had them, there was nursing there 24 hours. Other facilities that I go to right now, for example, there's one location that is advertised as a memory support facility. There is not a nurse, but here's where it gets funny. So the reg states that there has to be a nurse. It doesn't state the nurse has to be there or even within 3 or 4 hours driving distance of the location. So there'll be something called the corporate nurse, or she could be the corporate nurse. So she may oversee 3 or 4 different locations under this umbrella corporation. So let's call it the Pumpkin Corporation. Pumpkin Corporation owns 4 different facilities in, the East Coast of Florida. we'll say. They'll have the corporate nurse, and she is the licensed nurse for all the locations. So they're allowed to operate because there's a nurse, but there's nothing saying she's in the building. So here's where it gets funny. So pre-COVID, COVID and pre-COVID, I was more familiar with the model of the time was more of a nursing model. And this is speaking now, not SNF. SNF is not part of this right now. That's always nurses. Assisted living facility and memory support facilities. There was a director of nursing who was a nurse, LPN, RN, didn't matter. There was a nurse. There was an executive director. Mm-hmm. There was a sales and marketing person and or team. Then you would have an activities person, if you were lucky. This is like the glory days. An activities person, always CNAs, not home health aides. So you had CNAs. And that's kind of what the model was. They were 12-hour shifts. So the nurses would work 12-hour shifts, and they'd be nursing Monday through Friday. And the nurses passed the medications, and the nurses did the treatments, if so allowed, by that location. And that's how it went. Well, COVID happened. And when COVID happened, and this is just one humble nurse's opinion, I think an opportunity was seen. Because post-COVID, all of a sudden, you started hearing the term medtech. Yeah. And I had never experienced one. I had nothing against the medtechs, and they feel like I'm saying bad things about them, but I'm not. I have no problem with the medtechs. I mean, that's not.
And I want to clarify, because people kept saying that I am erroneously talking about medical technologists, which are more kind of like in the laboratory. No, that is completely different. We are talking about medication techs that administer meds.
Correct.
That's it.
So
now we're talking PO meds. Like, is that
well?
We'll get into that. We'll get into that.
Okay, because I'm just being
we gotta slow
devil's
it down
advocate here. I have no idea.
Yeah, let's let it marinate for a second.
Oh boy.
So, for example, in the location I was in at the time, one of my still very dear friends that I've mentioned, I think, on several episodes, she always ends up being in my stories, but my director of nursing, who at the time, who I'm still very good friends with, she didn't allow that. She didn't have med techs in her building. The ED at the time didn't have they didn't have it. There was one location that I was very familiar with, and there was a director of nursing who worked there. And I mean, and she was like a 40, 50-year-old. She'd been a nurse forever. She was like literal perfection. And post-COVID, when all the corporates started pushing this, God, you got to cut costs. When she heard they were attempting to bring med techs into the location, that's when she retired.
Mm-hmm.
And she said no.
She saw the writing on the wall.
She saw the writing on the wall. Now, to be fair, I can't say I did, because I had never had experience with them. I didn't really comprehend. I didn't know about the 2 hours on a Saturday or the 6-8 hours, whatever it is. People got on me about that, saying it's not fine, even if it's Saturday, Sunday. It's not nursing school. And so the med techs came in. And when the med techs came in, what that did was two things. One, it removed the need for 24-hour nursing. And two, it saved money.
But why did COVID change that? I'm missing that part of it. I don't understand.
The timeline is it happened during COVID, is what I'm saying to you is. So during COVID, COVID happens, the pandemic is, wrapping up, we're starting to get back to normal, and nurses just weren't coming back to these facilities, or the positions were no longer available. The reason
are you saying they were like the nurses were burnt out so that there wasn't they were.
I think that's a part of it, but I also think that the companies started to erase some of these roles. Like I'm not saying it's COVID that did it. 2020, 2021, it's just like in my area.
They took advantage of the chaos.
Right.
They took advantage of the veil, the chaos,
correct,
to get away with everything that they could possibly that they couldn't get away with before, correct, under the guise of emergency management.
Correct.
They knew they could legally get away with anything under the blanket of emergency management designation that all the facilities had.
Okay,
so
but
they
we're
did
not
what
in
they
that
had to
anymore.
do.
We're not in that anymore.
And that's the point. So everyone thought that maybe we'd revert back to it ain't happened. It's not coming back. And that's the thing is, it's not coming back. So
that sounds illegal. I mean,
well, no,
none
of it's illegal, because the way the regulations are written, the nurses aren't required, because the med techs can legally pass the medications. What they can't do, where we're going is, in certain states, in my state, they can't do injectables. They can't do insulin. They can't
Okay.
they can't assess for PRN need with narcotics. Like they're limited to that stuff. That's where you bring in the nurse and or the third party provider. Like there's layers to this. So it was
Okay.
just more cost effective. So in one facility in particular that I'm going to reference, in this location, I honestly, truly, at this point, believe I don't even think they're CNAs now. I think they're HHAs, just home health aides. And the director, the old role was the director of nursing, is now called the director of wellness. See, that's a new title that appeared around this time too. Director of wellness means this person doesn't have to be a nurse. This person could have stocked shelves at Walmart. There's only one requirement. Two, they have to be over 21 and they have to pass the ALF core competency course. If you do that, you can be a director of wellness of a facility. You can be an executive director of a facility. You don't have to have initials. You never had to go to nursing school. You never had to even work in healthcare. I know.
So that's the only requirement that a director has to have is to pass a
Pass your
test.
core competencies. You're done.
Wow. Here's where I'm confused though. Don't these patients need like a assessment by an RN, like a full assessment, or no? Uh-oh.
Are we going there right now? Are we doing that?
I don't know. Is that
All
a
right, so
question down the line? My brain is going.
No, we can
It's
take
firing thoughts.
we can take it as it comes. So here's how this goes. So assessments to these facilities, you would think that would be the case. When I was still in this role and doing this, they would send me out to do these things. Matthew would do an assessment, Matthew would do an assessment. So they need to be able to stand, pivot. They can't be a max assist. They can't be bedridden. Like there's layers to why because of the limited nursing services that can be provided. So I go see these patients.
Okay.
So and then the unit I was on at that time held 18. And so when I first got there, there might have been 9 or 10. So they were pushing really heavy for census. So they weren't really into like turning people down. They wanted the money. They'd send me on these assessments and I'd get there. The patient would be a 3-person assist. The patient couldn't stand. The patient, not patient, because you got to call them residents. The resident couldn't stand, couldn't pivot, was at risk for falls. Maybe Lewy body dementia was going to be a behavioral risk. Just wasn't appropriate for unit. So I would come back and say, like, listen, it's just not going to be a no-go. Administration doesn't like that.
Of course not.
They don't care for that. So what do? Well, the reg doesn't say it has to be a nurse that's assessing them. So next thing you know, the AL manager who had worked in finance prior and the activities director who did coloring and hula hoops and, balls for a living would go out and assess the patient and say like, oh, they're fine. They can come. Here's the caveat. The reg states that an MD has to either see them 60 days prior to admission or 30 days post-admission. So a resident could technically be living in the unit for 30 full days before they have to be seen by an MD.
Wow.
Yeah. Yep. So
you don't believe
just
me?
To kind of
Google it.
I believe you.
So just to kind of reiterate, because I don't know that this will land with people, but like they need to hear this. So what we have these days in many places, allegedly, is executive directors of healthcare facilities that have no prior healthcare experience.
Correct.
Okay. We have what used to be DONs, directors of nursing, that are now like director of wellness, that used to be nurses, but now maybe they were a med tech, maybe not. Maybe they worked in sales or marketing.
A lot of them did.
Yeah, but have no actual clinical training, let alone a degree.
Correct.
Right? And so we have facilities that are essentially also replacing nurses with med techs and CNAs. Right? Like that, I think that's huge and people need to
But it's the truth. And then
get that.
And in the comments where people are getting so mad saying, well, that not nurses, that's not what I'm saying. So an example would be this. Let's say you have a CCXR, okay? So that would be an independent living community an assisted living community, and a memory support community, all in one building. Okay, so like the circle continuum of care. So maybe at one point they moved into IL, which they don't get nursing, they don't get nothing. They're independent. They declined, so they usually do like a buy-in. So maybe it's like $1 million buy-in to get into this. Then they move into AL as they decline. And then after AL, if they decline more, they move to memory support. If cognitively impaired, if not cognitively impaired, they decline. They can move into the SNF or into the long-term care, the rehab component, which honestly, if used appropriately, is not a bad model. It allows them to age in place. Okay?
Right.
That ain't what happens. That's the thing. So just because there's a nurse, so there may be a nurse, let's even say, for shits and giggles, there is a nurse 24 hours. Let's say there's one nurse during the day, one nurse at night. So she is probably stationed in memory with, I don't know, say 30 patients. But then she has the responsibility of the 80 patients in AL as well.
Mm-hmm.
So now tell me what happens when she's in memory and that door is going off because there's an elopement, patient's getting out. At the same time, 4 patients fell in AL. Okay? And she's trying in the middle of a med pack. How is she triaging this when she's the only nurse?
Right.
How is that happening?
Yeah.
And then people wonder how errors and stuff occur. This is how they occur. I'll give you a horror story that I actually lived. And, they push these CEUs and, they'll tell you, oh, they know CPR and they know this and they know that. And they know their QESN, their person-centered care, and they've been trained. They tell you all this. I had a patient who I was going to see for wound care. And as soon as I got to the facility, it was apparent. I mean, he was in active cardiac arrest. It was active. And so he ended up being unresponsive, began CPR and compressions immediately. I'm probably on like minute 11 on my own. It's very early in the morning. It's like 6:45, 7 o'clock in the morning. And I'm there as the wound care nurse. I don't work for this location. And a CNA, HHA walks by in the hallway, and I'm like, help me, I rotate, I need you to do this. And, oh, no. I don't know CPR. I don't know. But part of the employment is that you have to be CPR. So what happens is, they're trained. What usually will occur is, I'm sorry, I'm going to say it, one CNA will do the Reliance training and do the course training, get all the answers, take a picture, and give it to the other 16 people that work there.
Oh,
and that's what happens with these trainings and educations that they're giving. I was doing compressions upwards. It was like 21, 22 minutes by myself until EMT arrived and then put this poor patient under the Lucas.
Now let's take a moment to hear a word from our sponsors.
I want to take a minute to talk about our good friends at Stink Bomb Odor Blocker, a fellow nurse friend who created these amazing ways to block horrible odors when you're working and you can't take it anymore and you got to block those smells. I got Irish cream this week and I am in love. It smells like a little bit of Bailey's put right into your coffee.
Nice. I see where she has a new one called Good Karma. I need to smell that one. And
like Taylor Swift.
A mistletoe one for Christmas. And did you know that you can build your own custom set? You can pick 4 of your choice scents, and I think there's like 18 or more different scents to choose from, and build your own little pack together. I love it. Yeah,
if you don't know what these are, you're living under a rock, you need to try it. But all you do is it looks like a lip balm. You dab it under your nose, and it's discreet. It doesn't embarrass your patient. Your patient thinks it's chapstick, and it helps block out all those horrible smells. So you can head to stinkbombodor.com, and she's generously giving 15% off. Use code UNCORKED15 and check it out. Get your friend a little holiday set. So speaking of CPR, withholding CPR is another taboo subject that you don't hear about. Can you give us some examples of that?
I mean, the example that comes to mind is the case that happened in California. I'm sure most of us heard about it. There was a patient who was having, I think it was either cardiac or respiratory issues, but regardless, was unresponsive, required CPR. And if anyone's heard that 911 call, it's
it was all over social media. You may have heard it. It was pretty
probably did.
Pretty
if
bad.
not, I mean, I'm sure it's Googleable. They can find it. But basically, what happens is the facility nurse is on the phone with EMS support and explaining that the patient, the condition the patients need, And the 911 operator is explaining to her, okay, she's like, well, you're the nurse, you can provide CPR. And then she's like, I can't. And she's like, what do you mean you can't? And she goes, our facility has a no CPR policy. And so then you hear the 911.
Imagine a healthcare facility has no CPR policies, and that's not isolated.
No, at all.
Why? Is that because they don't usually have a nurse there to do it or something? Or their staff isn't competent? I don't understand.
I mean, there was a nurse there, but this particular location, like I said, some of these facilities are able to make their own policies. This particular location had a policy that they did not do CPR. So that's kind of something that I'm assuming you would have been told upon admission that we don't do this here. So you would think everyone's a DNR. But
yeah, that's like you're making the decision to make them a DNR, and they're
pretty much
they may not. They may not be.
And the thing is, the patient can revoke their DNR status, right? If they are, mentally capable of doing so, right? They can do that in the moment. And so we're essentially saying, nope, we're taking that legally protected right away from you.
It was disturbing.
And do these families even know that, though? Do they know what, like, I'm sure that's another question we're going to get into, but I'm just thinking about it. Don't answer it now, but that kind of scares me a little bit.
I mean, it's terrifying, but as the call went on, and what I found the most interesting about the call is, at some point, a superior from, don't quote me, gets involved, and the nurse is asking, and she's saying, they're telling me to do this, and they're telling her, no, you can't. She goes, they're still telling me I can't do it. And then they're like, is there anyone nearby? Is there anyone you can pull off the street? And I think that was a quote. Is there anyone off the street? And the point
this
is
nobody... absolutely ridiculous.
Yeah.
This sounds so stupid. I mean,
but it's happening. Can you imagine? And like anyone, a passerby on the street can do CPR, right? It doesn't have to be a clinician doing it. And you've got the EMS operator on the phone saying, just grab someone. I'll walk them through it. I'll tell them what to do. And they're like, nope, we have a strict policy. No one can do CPR here.
But what benefit is that to the facility? Wouldn't they want them to live so they can keep paying them money monthly? I know that sounds horrible, but wouldn't that be to their advantage to get them going again? I'm just trying to understand.
I don't think anyone can understand why that would be the policy, because I'm telling you, I mean, I don't know everything, but I didn't even understand that policy. But what Erica just said is not an exaggeration at all, because that's literally how the phone call went down. Literally.
Yeah. And if somebody doesn't believe it, maybe we can link an article about it or something in
the video or something in the description. And kind of along those lines, so many facilities have like chair-bound, bed-bound residents who are no longer appropriate for an ALF, assisted living type setting. But facilities, they want to retain their patients, right? Because they want to keep billing for them. And so they do things like, this is another shocker, do not send out orders or do not send out policies. So they'll even have like notes posted at the nurses station stating which residents can or cannot be transferred to an emergency room, or that you have to call the family first to get their permission in case of emergency to transfer them. Or you have to call the one nurse, the district nurse that's 300 miles away to get permission to, and like the liability. Matthew, can you talk about the potential liability that has on the nurse that's there, that's assigned? Because I don't think they realize, they think, oh, there's a policy, so I have to follow the policy.
That's true. So like she was saying, I see it frequently, especially when I'm going to these locations. You'll go into the nurse's station to, give your form or give your report documenting, what you did, what wound care you did that day. And there'll be like whiteboards, and they'll be either written on, or there'll be a million Post-its, resident 209, do not send out. Resident 114, do not send out unless POA is notified. Resident 234 cannot be sent out. And they'll be everywhere. And I tried to research this as best I can, but again, state to state, it does seem like in some states, these do not send out orders kind of hold up in situations possibly where the patient lacks capacity and the POA has been activated. It's a very messy area, but what my whole thing with it is great, there's a policy. It's policy, fine. That doesn't supersede the role of the nurse. It doesn't supersede the Practice Act. It doesn't supersede our scope. Yep. So you'll have young nurses who, reek of NCLEX, let's be honest, and they just come into the profession. I'm sorry. They just come
reek of NCLEX. It sounds like a perfume.
Oh my
God. Are you wearing NCLEX?
Should we? Can you imagine? Anyone who's going to steal that idea, we're already going to copyright in front. So that's already taken. That's what we're going to do.
It's like you're squirting sweat droplets.
Can you hear the commercial?
And stress.
Are you burned out? Are you tired?
Do you reek of NCLEX?
Try NCLEX. And then she arises.
Oh my God. You might have a multi-million-dollar idea there.
Oh my God. Sick of being floated Try
You reek of burnout.
Yeah, right? And then at the end of the commercial, she sprays it and the guy whispers in her ear, "Your patient coded." Or something. And then
you're getting an admission.
You're short-staffed again. Again.
Or whatever.
I love it.
But bottom line is, the State Board of Nursing is not going to care one bit what your policy is. No. They are going to look at you when that patient's family reports you because you did not send, your clearly septic patient, let's say, to the ED, and they report you and you're before the Board of Nursing. The Board of Nursing is not going to care one bit what your policy says. They're going to look at you and say, but you knew better. You knew that you had an obligation to that patient. You let that patient die because of a policy. That policy is irrelevant. Oh, and by the way, give us your license. Right. And now you're probably going to be criminally prosecuted on top of it.
Correct me if I'm wrong, and I may be pulling this out of thin air, but I seem to recall, was there not a case in the last 4 or 5 where a nurse in one of these settings, the patient had fallen a few times, I think, in a week or two, and did not send the patient out because of the do not send out order, and the patient passed and the family changed their mind at the end, and the nurse got implicated? It was like they didn't want him sent out, but then when it actually was all over and done with, well, you should have sent him out even because you're a nurse. I do recall, maybe it was Washington. I could be wrong.
Do not send out order.
Yeah, do not send them to the ED because, God forbid, the beds stay empty past midnight and then they lose that ability to bill for revenue for them.
I swear it's like listening to this, it's like they want them to croak. Do they get a bigger check if they croak in the facility? I don't understand.
They just don't want an empty bed.
That, and a lot of times too, what you'll see is sometimes and this goes to the appropriateness. It all ties together. You will have a patient. Imagine you're the family, right? So it's it's your grandfather. And Monday night he fell. We're sending him out. Tuesday night he fell. We're sending him out. Wednesday night he fell. The family starts to become frustrated with this, and they're like, you know what? Enough. Enough. At no point is anyone having the conversation, we can't take care of him anymore. Because God forbid you lose the money. They keep them. And so it's kind of, there's 2 parts to it. There's the do not send out, and then there's the family who's getting woken up at 3:00 in the morning every night of the week, rushing down to the hospital because there was another fall. And now you're taking up hospital resources. EMS is coming over there. They're transporting them. The hospital's seen this guy 5 times in 2 weeks. At what point do we decide we cannot care for him?
He needs
now, I said to, if this was the hospital and we had a patient who was falling all the time, we're pulling a sitter.
Yeah. But they don't want to do that because,
Right. That's more money. Yeah.
Or it's at the family's expense. Now they have their family, they call the family and say they need private duty. Now the family's shelling out $350 a day for private duty, plus paying the $9,000 for dad to live there.
Yeah.
So what are you doing for them?
Well, if these aren't enough problems, I think that we should do our problem of the week before we get into the next question.
Problem of the week.
Let's tackle a different problem for a moment. What do you got, Erica?
Yeah. Well, I know that you received this and I received this, and Nurses Uncorked received a lot of requests to answer this question after one of our recent episodes about organ donation. People are concerned. Yeah. And the question is, how do I remove my name as an organ donor in light of all of the controversy? And so,
not that we're pushing for that. We're not saying for you to remove your name. We're just saying it's a question.
Here's the thing,
people
like
ask.
we want to answer it because people are asking. We want to provide that information, but we are not saying anyone should go and do that. You need to make your own individual choice, but also keep in mind that even if you're not listed as an organ donor, you can and should have that conversation with your family to say, I would like to be an organ donor, but I am leaving that decision in your hands to make sure that it's handled appropriately so that it's not 36 hours after I've been hospitalized that they're forcing you to do this. You know what I mean? Right. So what I found out was that you can go to your state's organ donation website. You can literally just Google the name of your state and organ donor website or network. But in most states, there are two separate registries. So you have to kind of unregister yourself twice, which most people don't realize. So there's the National Donate Life Registry, which is registerme.org, and I'll link it in the description. And you just click on edit registration. And you can also, if you registered at the DMV, you can go to your donor registration in your state donor registry. But both your state donor registry and the National Donate Life Registry are checked by donation professionals at the time of death. And it's your most recent donor registration that is what is going to be honored. So I have also heard from people recently that are trying to do this and are reporting that it seems like it's being made allegedly purposely difficult to unregister yourself. And so I have been listed as a donor, organ donor, since I was, 18 years old. And I decided to unregister myself. That's just my personal decision. And so I tried in Nevada. And it has you enter like your date of birth, the last four of your social, your driver's license, ID number, all of that stuff. And it consistently says that my information is not recognized. Well, my information has not changed since I was 18 years old. So I find that to be a little bit concerning. And so I have emailed directly saying, this is what I want to do. How do I do this? And that was just very recently. And so I'm waiting for a reply on that. But again, it's
I envisioned in my mind like that they look at your driver's license and see if it's on there. Like, to me, that is what I thought happened. But I guess they're going off of a site
registry.
That's what I thought. I was like, it either says yes or no on there, and then they kind of went off of that. But
I think it's more like a state and or national database that you're in, that they just immediately look up your name. And the thing is, like, your family doesn't have say so. If you're over 18 and you're in there and you're listed, your family does not have any say so.
That's what I heard, is that they can override if the family doesn't want it, but you have it. They
legally
don't
binding.
Listen to, which nobody's even getting informed consent in the DMV. But that's a whole nother, that's a whole nother can of worms.
That episode was scary when I watched that episode.
I know.
Yeah,
I know.
That's very scary,
and a lot of people coming forward now as a result of that. But so that's the problem of the week.
It sounds like if you want to remove your name, I would suggest I would do all of it. I'd go to the DMV, update your driver's license, find out what the registration things are in your state, try to get it removed like Erica did, and then if you can't figure it out, keep emailing, or I don't know, there's got to be a number too that you can call some of these places. Sounds like a pain in the ass, but
yeah, it does.
Anywho,
Well,
Yeah.
let's get back into it. So I have a question
Yeah.
for you, Matthew,
Mhm.
and that this is one that we had talked about. There recently was a possible precedent-setting case out of Ohio where a nursing home patient's death has been ruled a homicide. This is a big deal. The
Mhm.
autopsy lists the cause of death as sepsis related to caretaker neglect resulting from complications of a stage 4 sacral pressure wound. The family has filed suit and alleges that this is because the caregivers there, the facility stopped getting the patient out of bed to the chair, repositioning them, and that
Correct.
this wound developed and they were not even informed of the wound.
Correct.
So do you think that this will start possibly a cascade of similar lawsuits? And number two, who's ultimately responsible? Is it the nursing staff or is it the facility that staffs them so irresponsibly?
It's the med tech.
Yeah. So I'll answer the first part.
We don't want to vilify the med techs. We don't. But
No,
it's a
I'm
problem.
I'm being funny by saying that a lot of times, like, there's nobody there. It sounds
Well,
like, so
That's
honestly,
true.
honestly,
I mean,
pause. There's a way it could go that way, but to answer the first part of the question, this is the topic that really gets me, because anyone who's listening who's not medical doesn't know, a stage 4 doesn't just appear. Doesn't just appear. Like it took some time to get there. Okay, there was warning signs prior. You understand? I mean, I'm not talking about a Kennedy that just shows up out of nowhere. Like a state, this has been there. So the first part of your question, I 100% hope it does, and I 100% agree with this particular charge, homicide, manslaughter, and I'm all for it. And I hope it's a precedent case, and I hope moving forward, other cases of this nature get to reference this case as the precedent case, because it is. It is.
Yeah. But who are we going after? Because the facility will make the nurse the scapegoat 100% of the time.
Don't
even
they
if that
always?
facility forced that nurse to have 60 patients and no CNA or whatever.
So,
like they will say it's the nurse's fault.
So who's responsible? So we're gonna run the actual Nightmare on Elm Street. So if this nurse, I haven't done the numbers. I don't know how many people were at this location, but I do know. I mean, the family, in reaching out to comments, stated they didn't know about it. Everyone was saying about, she was on hospice. She was on hospice. The family says she was on hospice 1 to maybe a week and a half before her passing, so she wasn't on hospice, because they try to use that as, well, hospice patients can be bedbound, so that's how this happened. And that's another thing that really infuriates me. But so the Nightmare on Elm Street, how this happens is you have the one nurse, let's say there's 60 residents, okay? You would assume there's weekly skin checks. That's SNF. That's skilled nursing facility. We're in AL. We're in AL right now. Maybe they're doing a weekly. Maybe that facility's asking for a weekly. Maybe they are. Maybe they're not. But even if they are doing a skin check, it's usually just a CNA coming in, popping her head in the office with her little paper. Yeah, everything's fine. The nurse signs up. She never really went and did anything. Yep. So if it wasn't brought to her attention, she didn't know. What is unfortunate about that is, being the nurse and accepting the assignment, it is her responsibility.
Yes,
it is. She didn't do her due diligence and go look. She should have been aware. There should have been a skin check. And repositioning Q2 is the most basic of nursing tasks.
It is. It's like day 1 of nursing school. Day 1. Yeah.
So, and to that point, if you have a patient who's not standing, who's not pivoting, I even have a hard time with that. Let's just say they're probably not appropriate for the floor and maybe needed a higher level of care. But if the facility never had this conversation, isn't telling anyone, they're just letting it ride. They're letting it ride. At minimum, even the bedbound patient should be rotated and pillowed and lit at minimum. Correct. So
but where is the staff to be able to do that?
Well,
it sounds like they don't have it.
Well, that's another problem too. So there could be I mean, in one building that I know of that has, how much they have? There's 45. There's one CNA per unit. So each one has like 30 something, 40 something. There's one CNA, and then there's a med tech that floats between the groupings. So how she's doing that, she isn't. Hopefully there's a float. Maybe there isn't a float. If she needs a CNA's help from another unit, then that CNA is abandoning that area to come help her. Like, that's how these things keep happening. You know what I mean? So it is definitely, it's a combination. It's staffing issues. It's people just not doing their job, not checking skin, not looking. And how it occurs is, if you think about when you go to, like we said, about the contact hours and stuff, with such small staff, they only have so much time to get so much done. So if they have 40 people that they have to get up for breakfast by 8 a.m., what type of washing and showers are you thinking they're getting?
Nope.
Right.
Yeah.
A little
You know what
white.
this reminds me of is that one case where that I think it was an LPN maybe that was supposed to, or maybe she was an RN, but it was supposed to be doing the Q 1 hour neuro checks because the patient had a fall,
Yeah.
and she couldn't keep up with the neuro checks, and she ended up getting
documented it
charged.
anyway.
She documented that she did.
Criminally
Yeah.
charged.
Yeah.
Yeah.
But
I mean, that's scary.
That's how these things happen, and it's like, you know. So I know for myself as a home health wound care nurse, if I could tell you the amount of stage 4 and unstageable sacrum coccyx wound that I see on the week to week, we'd be talking for hours.
I'm sure.
It's all of them. They're happening and that's what happens. By the time we get the call, we're like the last stop. Like, can you make this go away? Because they know that now they're in it now. Can you please make this go away? Can you please? That's what they want you to. They want it to go away. They want it to disappear. And what kills me is when you then talk to them and say, like, this isn't progressing how we need it to. The conversation, and this has happened to me, becomes, oh, well, it wasn't a 4 when the referral was sent to you. It was just read.
Right.
You
That's
guys
not what the
did
picture
that.
says.
Well, and then you pull up the picture from the start of care, and then the conversation goes away. But that's what they do. They just it's utter neglect, and I feel so. And what kills me about that particular case, she was only 72.
Yeah,
she was only 72.
Yeah,
right.
Not that death at any age is acceptable, but 72.
You know what scares me, though, is that this probably happens way more times than we even know, but families probably don't even know to push the envelope on it to say, this is wrong.
Or to roll them over and look because they weren't told there's anything to look at.
Well, that's what I'm saying. You hear as a family member, okay, all of a sudden you hear your mother has a stage 4 pressure wound. People that don't know are like, oh gosh, like, okay, that just must have happened because that's part of what happens, like, when you're not moving around as much. Like, some people don't even know to ask questions or to say this was wrong. Why wasn't this brought to our attention a long time ago? Like, I'm saying there's probably is a lot of these cases that just don't come out to the forefront, you know?
I mean, even people that do know, sometimes they're trusting. And they're trusting the staff is doing what they're supposed to do and don't realize until it's too late.
Yeah, and sometimes there's like medical gaslighting, you know, where, okay, you're not medical, you don't have that education, that background, and you have someone that, you know, does, standing in front of you saying, you know, a lot of things that maybe you don't understand, and you just kind of go, oh, okay,
it's true,
you know, like, I guess that's it.
To Jessica's point too, the ones that don't know, then you have the grouping of the ones that do know. And in these locations, and I see it all the time, if you're the family member that advocates too much, you're the problem family.
Yes. Yes.
You're the issue.
And you don't want to be that person. That's a fine line because you have to advocate, but then you don't want to have them retaliate against your loved one because you've complained too much. That's hard.
That or the good old 45-day. They love to give the problem families a 45-day notice. Like, you have 45 days to move, Mom. Sorry, got to figure it out.
Because you're you have 45 days because you're a PIA.
Yeah.
Yeah. Pain in the ass. Yeah.
Pretty much. Yeah. And that's how it goes. I mean.
And then they're in a panic because they're, you know, that's so hard to get placement to begin with.
Mm-hmm. Or then what they do is they'll go and beg, no, please, and now they never say anything again. They've been scared into submission. They don't say a word. If you go on the Reddit forums and you research this topic, you'll see so many families around the country who say things, and a lot of them say stuff like, I learned to choose my battles. I learned to pick my battle, because they would try to advocate, and all that ended up happening is their loved one just got worse treatment because of it.
Scary. I'm going to switch gears a minute here, and let's talk medication errors. I'm sure this is a hot topic.
Lord Jesus.
So allegedly, it's a big topic, and there's a lot of medication errors that go on in these facilities, and they're covered up.
Mm-hmm.
Why do you think that that's happening, and why is this happening so frequently in these settings? Med errors and the cover up, all of it.
Asshole, choose your words wisely, baby. Oh God! All right. Well, let's just do it. Let's just do it.
Yeah. Tell us the truth. We want the truth.
So how do med errors happen? So we all know. I mean, we're friends with one. We all know that even the most experienced nurse, who doesn't mean any ill intention, can make a mistake. We know that even someone of that education level and that many years in the game, they make a mistake. What do you think happens to someone who did a 6-hour class on a Saturday? And I say this with all grace. I'm going to say it, and I know they're going to spin it and take it in a way it's not supposed to be taken. A 6 to 8 hour class on a Saturday. There's a language barrier. Okay?
Mm-hmm.
There's a language barrier.
Sometimes, yeah, there is. Mm-hmm.
Yeah, it can be.
And they're thrown onto a floor, and they have to pass pills for 40 people.
Mm-hmm.
Mm-hmm.
Okay? Is that not the perfect? Is that the perfect recipe for a mistake?
Yeah. Sounds like it to me.
Here's where the mess happens too. They don't know to look for certain things. So let's say somehow there was an accidental double entry. There's an old order that should have been discontinued but was not, and it's still active. And the new order has also become active, because some of these systems link right to pharmacy, and pharmacy deals with it. Some of these systems don't link right to pharmacy, and it has to be faxed. It just depends on the location. You may have two orders of the same medication.
Maybe two different dosages. So they think, oh, well, it's appropriate. They don't think,
boop.
Like maybe a nurse would question it and go, I think this is a duplicate and needs to be DC'd.
Right. Like, let's say they increased somebody's Coumadin or something. Like, they increased it, but then there's still the other one on there. Like, and then
can tell you a story of a patient we were treating where, based upon the bleed and what was going on, we ended up having to ask questions, and it was this exact situation, that there was a dual Coumadin order running, and had been for some time. And the problem with that is they, and again, not, crapping on the med techs, but they don't know necessarily what they're looking for. And I promise you, and this is the truth, the 5 rights, 6 rights, whatever, how many rights it is now that they're doing, that doesn't happen.
The 20 rights.
That doesn't happen. I'll tell you why it doesn't happen. Because in a lot of these locations, it's not like it is in the hospital, there isn't an armband. Mm-hmm. You're not checking an armband. It's mostly, even if I go in and I say, where is Miss Erica? Oh, who that? Miss Erica. Oh, blonde hair. They don't know the patient's name.
Blonde hair.
Yeah.
Or they'll call that one wheelchair.
Blonde hair, really bitchy. Oh, yeah, we know
but
that.
I'm telling you, because they don't know. So these are how these errors occur. And in certain facilities, and especially during the hurricane, we've seen it, where there isn't a nurse. So where there's the DOW, there's the ED, corporate nurses, wherever she is, I don't know where she is, and there's just these med techs, and there's no actual nurse there. They have something called cycle, where pharmacy will come in and actually cycle out their meds for them. I've spoken to the girls who do cycle, and they tell you how many mistakes they've found, how many old orders are still there. I had a patient who I was treating. I was in the room when this happened. It was a married couple, and we were doing care for her husband had a name that, I mean, maybe back in the day could have been seen as a woman's name. Not common, but it could have been seen as a woman's name. And the med tech came in to give the medication. And she looks in the cup and these aren't my pills. Yeah, those are your pills. No, these aren't mine. No, they are. Well, what are they and what are they for?
Couldn't answer.
What had happened was she was a retired RN. They were her
patient.
husband's pills. They weren't her pills. You know how many times that happens? You know how many times the families aren't told about it?
What do you mean they were her husband's pills?
Because it was both
her husband had a feminine name. He had a feminine name.
But they were both residents there.
In the same apartment.
I see. Okay. Yeah, sometimes they do share little living places together. I get you. So that's why they got, oh my gosh.
Or what about they have to pass meds on 50 patients? And so instead of taking that med cart room to room and individually dosing out those meds for that patient outside that room, they are doing it ahead of time. Yep. And they've got their little tray with 50 different med cups sitting on it,
and then they all spill as they ride over.
Yeah,
they spill as they ride over a bump.
This is medication safety 101. But what can we really expect of them when they are given a 6-hour, an 8-hour, a weekend class, and they have
blue for you, pink for you?
Yeah, they have no
speckled pill for you,
pathophysiology to check a blood pressure, to see if we should hold the hypertension meds or any of that. You know, like this is just basic nursing, and they're not getting any of that.
I told you in the last few weeks we were reconciling a Ma. They had amoxicillin. It was given for hypertension. That's how it was written out. Amoxicillin for hypertension.
Who knew? I didn't know you could.
No, I'm sorry. Like,
we
and you know what they
laugh, but like,
but this is like
I really want to know the
insane.
pathophys of that.
Right?
It's amazing. Maybe you feel better that your infection's going away, so it brings your blood pressure down.
And you want to know what gets me upset about this? Because, and this is where I'm saying I'm not talking bad about them. So with these med techs, these, you know, they're just trying to work. They're trying to provide for their family. They have not. They may not necessarily even comprehend the level of what they're doing, because they went to their little class, and their little class gave them their paper,
and they're like, told they're safe to do this.
We're good to go. And the other thing that gets me too is in a true assisted living facility. Okay, and again, every state can be different, but for us, you cannot administer anything. The patient.
So explain that to people.
So the patient has to be able to. So, I mean, you can go to the room. You have the little blister packs. You pop the little pills in the cup, and you say, "Hey, Miss Jessica, here are your pills." Miss Jessica will then take her pills. Now, if Miss Jessica has limited dexterity of fingers and hands, you can help Miss Jessica. Watch how I do it. I can help you with your hand to get your pill. Mm-hmm. They can't do this, and they sure as shit can't do this crushing in a cup with the pudding and spooning the pudding in the mouth. Because all these patients, all they get, that's all they do. You'll see a row of cups with puddings and applesauces, and they're feeding them. And seriously, and you'll see these patients, limited dexterity, maybe cognitive impairment, and they're like, they don't know, and they're just shoving it in the mouth. This is how we get to the med errors. This is how they occur.
Mm-hmm.
This is how they happen.
Yeah, and it's prolific, and it's being covered up, and we're not allegedly, and we're not being told.
Oh, no, redact that. There's no allegedly on that. We'll redact that allegedly.
There's no...
Because that's happening. There's no allegedly there. That's what's happening.
Okay. Well, and again, there's a lot of people that get very upset that, you know, what some med techs can do in some states, it differs state to state, right? So they can, in some cases, do insulin, which honestly to me is terrifying.
Wow, really?
Yeah, like, yes.
And that in my hospital, you have to have 2 RNs check off on insulin, but
correct.
In some places you can just with a weekend class.
Yeah, some states are saying that they can do here. Here is a no. But some places apparently allow it.
Yeah. And again, we don't want to bash
Crazy.
on med techs. There are some great med techs out there. But I think most people will agree that the education requirement is severely lacking. And there is a ton of research to show that it has, negative outcomes, right? Patient outcomes. But also I want caveat to that. If you are a med tech that is calling themselves a nurse, that is illegal. You are misrepresenting yourself as a medical professional. That is actually a crime. You cannot do that. And I have a real problem with that. Anyway, moving on.
Made me think that just made me
She digressed. Erica digressed.
I always
that
do.
made me think of a story.
Right.
In one of these locations, there was a med tech who they were in between DOWs at the time and was an interim DOW. And it was
Director
the first
of
time I gone to
Wellness.
that.
Wait, what's a DOW? Am I supposed to know what that is?
Director of Wellness.
Oh, okay.
And,
the ones replacing the DONs.
Right.
Okay, gotcha.
It's
okay.
the first time I'd been to this location, and so we have like these ALF forms. So you'll write like, skilled nurse assessed all bodily functions, cleanse wound with normal saline, pat dry, wash moist gauze, what was the treatment you did, whatever you did, and you hand them in. And there's a section at the bottom that says report given to. So I saw the gentleman, and I said, "What's your name?" And he told me his name, and I said, RN LPN. He was like, "Oh, LPN." I put it there, and so I was like, I went to go put it in the file. I was like, no, don't worry about it. I'll file it for you. Came back the next week. He wasn't there, and so I went to go file my own paper, and I looked at my paper from the previous week, wasn't there. It wasn't until a month or two later, come to find out, the reason why that paper wasn't there, he wasn't a nurse. And he didn't want me putting that file in there that he wasn't in the paper, because he wasn't really a nurse, he was a med tech. But he was telling everyone he was a nurse. And
that's illegal.
We all believed it. We believed it.
Yeah, that is actually a crime, and you should be reported.
So after all of these things that we've been hearing about, all this horrible stuff that's going on in these facilities, I think we need to segue into our Enema of the Week award.
Enema of the Week.
So I want to highlight our Enema sponsor of the week, Happy Bum Co. Matthew, as our guest, I think I should ask you, have you ever heard of a coffee enema? Is that something you've ever heard of as something that you can do?
I mean, I've never heard of it. I'm intrigued to know what a coffee enema is.
Coffee enemas are not a new thing. It has been around for a long time. It can certainly help, as any enema can, with things like bloating and constipation. People report things like increased energy levels and improved moods with coffee enemas. Tell them where they can get it.
You can go to happybumco.com, and you can also get 15% off your first bundle by using our special code Nurses Uncorked. You should definitely check it out because they have tons of amazing products to offer.
This week's award goes to none other than UMCNO, which is University Medical Center of New Orleans. If you have been watching any of my videos recently, you know that those nurses recently went on a one-day strike, and the hospital went allegedly on a full-fledged gaslighting campaign, allegedly putting flyers out that I have shared all over the facility. And I just want to share a few of the highlights of some of the things that the flyers have said.
Please do,
you guys,
because this is comical.
It's truly perhaps the very worst, most egregious example of healthcare organization gaslighting that I have ever seen. And that's saying a lot, right?
Yeah, okay. Please read them, Erica, because I enjoy this when Erica reads these.
If she's going to read the ones I think she's going to read.
Yeah.
It's bad.
So in response to the nurses giving their 10-day strike notice, the hospital put out flyers that said things like, if you don't like it here, leave.
I've heard that personally. Go ahead.
If you want to be paid like a professional, act like a professional. You're turning your back on the most vulnerable patients. It's patients first, always. If your employment is so under par, go elsewhere. Why are you even here? Parking at work is optional because that's one of their gripes, is because they have to pay hundreds and hundreds of dollars a year to park at work. So this hospital allegedly had the audacity to say, and put it in writing, no less, parking at work is optional. be grateful that the patient's parking is validated. I kid you not. Use your time off during the strike to apply at a competing hospital. So they also have taken it upon themselves in the flyers to vilify the union, which is National Nurses United, the largest nursing union in the country, no less. And it says, that union, they had the audacity to come into a non-union state, Louisiana, which a year ago they did. And that was a huge triumph. And the union is gaslighting these nurses into believing that they work in poor conditions, that nurses are just mindlessly following the union. They can't independently think for themselves. Well, the whole reason the nurses unionized in the first place was because they weren't happy with their conditions. It's not because of the union making them, come on. Just, yeah.
I almost feel like, is my ex-nurse manager running this place?
Might be. Mine too. I have a couple. Yeah.
Everything you read off of there is shit that I've heard, literally, from
Can you imagine
my old nurse
in
manager.
Writing, if you don't like it, leave?
I love seeing it.
Can you imagine?
I was in my car and I was at a red light and I'm looking, I'm scrolling. And I was like, I kept it open and then I pulled into the Walgreens. I'm like, hold the fuck. What did she? I'm like, what? They did not. No, that wait. Let me replay one more time. And then Erica leans in her head like this, and then the parking thing just got me. The parking thing just got me. The parking thing killed me.
You should be grateful that the patients and families get their parking validated. Screw you that has to come to work and work for 12 and a half hours. You don't have to park.
Yeah, why isn't my parking validated? Why isn't my parking validated?
I want to see.
What the hell?
I really do. If she's listening, because all the trolls listen. Whoever formed that document, I really want to see you. I want to see the face of the person who formed that document. I have an image in my head of what it looks like, and I just want to...
Yeah, she looks like my ex-nurse manager. That's exactly what she looks like. She looks just like her.
It's so bad.
And she has a Karen hairdo. I'm sorry, but she does. She has a traditional Karen hairdo, and
like
she followed it up by,
Katie.
There's a million other nurses willing to take your position.
They always
so if
say
you're
that,
not happy,
but there isn't.
If you're not happy, then you should look for something else.
So this week's...
That's what I want to say.
There it is. So this week's Enema Award goes to University Medical Center of New Orleans for gaslighting the nurses who simply exerted their federally protected right to go on a 1-day strike.
Congratulations on you, Enema.
Well, I don't know what to say about all that. There is just so much information here that we're going to have to make this a 2-part episode, and you're not going to want to miss out on the second part. We're going to be going over all of the tips and red flags that you should know about and look out for if you are ever in the position of having to put a loved one into a long-term care facility. This second part is really important. We're going to be getting down to some personal details, and you don't want to miss the story about the patient that got left in a closet and they found him 5 days later unalived.
I just want to thank you, Matthew, for coming on and sharing your story and your insight. It's really important that we get this out there, and we love you. And
love you
thank you so much for trusting us to tell your experience and share it with them.
At the end of this, and I'll quickly say this, I just hope that this video gets to someone who is sitting home right now, ripping their hair out, not knowing what to do. They have to place mom, they have to place dad. And if this just helps one family, I know it sounds so cliche,
it's going
corny.
No, it's not. It's going to.
I hope so.
Yeah.
Where can people follow you, Matthew? I know that I know where it's at, but where can people follow your video content?
TikTok, the Massel Liquido. That's it.
Until next time on the next Nurses Uncorked.